This is Michael Zaretsky from the Colorado Fetal Care Center inside the Children's Hospital of Colorado. I want to talk to you about a procedure called FETO. FETO stands for fetoscopic endoluminal tracheal occlusion and is a prenatal treatment that is used for moderate to severe fetal congenital diaphragmatic hernia. It is an experimental procedure that is hypothesized to improve the survival in these neonates. How does this work? Well, research on the effects of tracheal occlusion actually goes back as far as the 1960s and 1970s. This early work was performed in the animal lab, and in that setting it was shown that when the normal egress of fluid from the trachea is blocked, which subsequently force fills the lung with fluid, there's a significant stimulus for lung growth, and in parallel, growth of the lung vasculature. Further research was done in the 1990s on animal models with congenital diaphragmatic hernia, because with CDH, there is significant pulmonary hypoplasia and resulting pulmonary hypertension. So as shown by obstructing the trachea in these animals with CDH, you can significantly increase the size of the fetal lung, and theoretically, you can improve survival outcomes for CDH. An initial study in the United States was performed nearly 20 years ago. This initial study did not show benefit of tracheal occlusion, and those that received treatment delivered at a significantly earlier gestational age. There were two reasons why there was no proven benefit. One reason was that survival rates for conventional treatment were found to be much higher than anticipated at that time. The second reason was that patients that were included in the study did not have severe enough CDH disease to show a real benefit. These investigators first utilized a tracheal clip utilizing multiple ports to gain access to the fetus, and this required an exit procedure for subsequent removal of the clip. They then transitioned to using a single port for placement of a tracheal balloon to achieve tracheal occlusion. Around the same time of this initial study, a FETO working group was developed in Europe, and criteria were developed for what constitutes severe congenital diaphragmatic hernia, utilizing the observed to expected lung head ratio, or O to E LHR. If the O to E LHR is less than 25%, then this constitutes severe disease, and up to 35% constituted moderate disease. And patients are currently being enrolled in the moderate and severe total trial in Europe. In North America, a FETO consortium was developed to participate in these ongoing European trials. Inclusion criteria for severe disease in the FETO consortium is less than 25% O to E with liver herniation, and for moderate, up to 30% with liver herniation. The TRACE method is preferred for determining the O to E. There are strict maternal and fetal inclusion criteria for the study. For the severe arm of the study, the balloon is placed between 27 weeks and 29 weeks, 6 days, and for the moderate arm, from 30 weeks to 32 weeks and 6 days. So how is this procedure done? It is done under regional anesthesia, and a 10 French cannula is inserted into the uterus just above the midline face of the fetus. A curved fetoscope with a tiny balloon, shown here in this image, is inserted through the cannula and directed into the fetal mouth and then directed into the trachea. The balloon is then deployed, inflated, and detached just above the carina. At 34 weeks, the balloon is either deflated by a needle procedure or by a repeat fetoscopic procedure. In the event that this does not occur, an exit procedure may be required. The reason the balloon needs to be deflated prior to delivery is that surfactant production does not occur when the balloon is in place. By releasing the production, surfactant production commences. This plug and an unplug sequence was borne out in the animal model. Whether FETO is determined to be superior to conventional therapy for congenital diaphragmatic hernia has yet to be determined. There's ongoing debate in some centers where outcomes for conventional therapy in the setting of severe CDH is quite high. Additionally, there are concerns with the higher rate of premature delivery after FETO is performed, which may complicate treatment and survival for CDH. At the Colorado Fetal Care Center, if the family presents with a severe congenital diaphragmatic hernia, we will discuss the option of FETO as well as discuss our own survival rates for conventional therapy so that the family can make an informed decision whether or not to participate in this ongoing research.